Good afternoon, everyone. Thank you for joining us today for what we're sure will be a fascinating webinar. Big topic today. We're talking about trade tensions, US health policy shifts, and new global alliances, and how they are shaping patient access, workforce stability, and clinical decision making in the in the UK. Oh, hang on, I need to click on here. There we go. So my name is Glenn Ferris. I'm the Managing Director of Healthcare Today, and I'm joined by an actual expert, Dr. Adam Brown. He's an emergency physician turned healthcare strategist, the founder of ABIG Health. It's a Washington, D.C. based firm which advises healthcare organizations on strategy, innovation, telehealth, and communications. As I mentioned, big topic. Today we're talking about healthcare's increasing exposure to geopolitics and how US decisions on tariffs, drug prices, and regulations are influencing what medicines the UK can procure and prescribe, which in turn tests the resilience of public health services to global shocks. We'll be examining how political decisions made far beyond the NHS are translating into real-world consequences for UK patients, clinicians, and health leaders. Now, a little bit of housekeeping, as you have to do with this kind of thing, there will be an opportunity to ask questions at the end of the webinar, so please put any queries in the chat box as we go along. But in the meantime, let's get started. Adam, I'm going to chuck some questions at you.
Oh yeah, well it's good to be here. Thanks, Glenn. I appreciate it. And it's nothing like starting off with a light topic. Here in Washington, D.C. in the morning, it's something light, but let's get cracking.
Well, you threw yourself into the world, so
I
we can
did.
ask you the questions. Now, just looking at the last couple of weeks, the world is moving pretty fast and with incredible uncertainty. In your opinion, what are the most urgent US political shocks the UK health sectors need to prepare for?
Yeah, I think it's a great question to start off with because what we certainly learned over the last several years, especially with COVID, is that policy decisions that are made, healthcare issues that happen, do not just stay contained within one country. And of course, with Trump's ascendancy to office this past year and a half, we've seen it feels like it's been much longer than that, but just a little over a year ago, there certainly have been policy decisions that have been made that have, of course, direct implications. I think there are four major ones that I would kind of highlight, some that are more broad and some that are more direct. And the first one is, and I think this is one of the big things that the UK, the world, and of course the United States need to continue to focus on, is how to combat misinformation. It's the first time that we've seen in the United States that our head of health and human services, your equivalent to your minister of health, is spouting or saying things that are demonstrably false, that are anti-science type of rhetoric. And because we're in this very broad ecosystem of information and a swirl of information, it's becoming increasingly challenging for patients, for doctors, for policymakers to be able to identify what truth is and what's not. And so when you have health agencies at the United States level, which were oftentimes seen around the world as gold standards, and not to say that we're exceptional, but for a long time there was a sense that when the United States had their scientific rigor behind policy decisions coming out of the Centers for Disease Control or the Food and Drug Administration, the FDA, or HHS, Health and Human Services, that it was bounded or founded on scientific rigor, and we can't say that anymore. And so that first thing, the policy decisions around letting someone be the head of a health agency that has been anti-vaccine, have been a vaccine denier, and someone who will spout things that just are truly wrong, and most doctors know it, is something that the UK is dealing with. And let me give you the two reasons why. One is with vaccines. We now are seeing a growth in measles in the United States at levels we have not seen in decades. You too are seeing it. I was just got back from London on Sunday night, and one of the stories I was reading about was a measles outbreak in London. There are reasons for that. It's because of misinformation. The second issue is with paracetamol. I remember vividly several months ago, RFK Jr., Mehmet Oz, the head of Center for Medicare and Medicaid Services, standing with Trump talking about Tylenol being implicated in autism. And which is completely false. Study after study has shown this to not be true. But what are the implications now? Now, in emergency departments in the United States, Tylenol prescriptions have fallen, or giving Tylenol to pregnant women has fallen, leaving women who for years have been using Tylenol for pain control and fever control, which has proven to be safe and have no correlation with autism, is now something that we're seeing implications of. That trickles over and that crosses the pond, those words and those things. So I think the first political shock, and I'll get to the other ones more quickly, but the first one that I really want to hit on is this misinformation and how you deal with it in the UK is going to be very important. The second is the chaos in the halls of regulation around the FDA and HHS. There are direct implications for companies that want to commercialize their products, their services, their devices, pharmaceuticals in the United States. That has become a challenge for companies to be able to say, really, how long will it take us to get through the FDA? Will our product or service be approved? Is there going to be scientific rigor there? Are there enough people to be able to actually review our products? And so I'm hearing from clients and hearing from individuals saying, like, maybe we should try another country before. And when the United States has a great potential for profitability just because of the money flows, the lack of pricing caps, that has implications to companies that are in the UK that want to commercialize there. I think the third thing is that, and this is the more direct thing that took place more recently in the winter in December, was the December deal with the UK and the US on the back of tariffs. And it's really one of the, I wouldn't say the first time, but it's a very clear indication that the US's frenetic policy around trade and around tariffs have had now direct implications on the NHS's financial planning. As a result of trying to avoid the tariffs, Starmer's government and the Trump administration came together with a plan that would essentially raise the pricing thresholds that the NHS could pay for new drugs. As a result, that could be good in some ways, in some respects, for patients in the NHS of having more access to innovative technologies and drugs. But on the other side, there's a big budget implication. That could have a 1.5 billion pound hit to the NHS budget, which we already know is already having some significant issues. So this deal, this shock from the tariffs, clearly have direct implications. And then I mentioned this a bit before, but I think the fourth is just we talked about the regulatory chaos and how businesses and even governments like consistency with regulations. But I alluded to this, that the capacity of the FDA and Medicare and Medicaid to be able to look at the safety and efficacy of drugs and of devices and determine pricing on what they will pay, that has been significantly reduced because of the massive cuts in those agencies.
Hmm.
And so that has implications in the UK as well for any of the companies that want to commercialize here.
To compound that, the UK sits between US innovation and policy and EU regulation and supply chains. To your mind, is this a position of strategic flexibility or a position of vulnerability?
You're not going to love this answer because I think it's both and it depends. You know, I would love to be able to say that, I think is the UK is in a great place of flexibility. And I think in the past, they were able to pull from your country was able to pull from, the United States and the EU, depending on what the policy issue was or where they wanted to go. But what we're seeing happen is a growing protectionism that's occurring between the United States. And that kind of has implications from, okay, we've just talked about the tariffs and we've talked about how companies who were planning to build manufacturing plants in the UK are now, because of tariff threats, moving to the United States. AbbVie, AstraZeneca, for example, they are doing that. So having this flexibility has now created more vulnerability on the part of the UK. And so I think the question really is, what type of new alliances will the UK need to make? And have to put a stake in the ground that, okay, this is our new trading partner, or this is our new person that we're going to be hitching our wagon to, versus having a little bit more flexibility. Oh, we'll do a little bit of this from the EU and a little bit of this from the United States. I think that even though the United States is very dynamic in their innovation and have lower thresholds, we still are going to see this vulnerability that the UK has if as long as Trump is in office and as long as some of these policies and plans have been going into place the way that they have, and they're going to need to have some of that flexibility, but also they're going to have to need to make some decisions about who they're going to partner with, and that may not be their normal type of alliances that they've had before.
Hmm. Trump's hugely touted Buy American policies and then the FDA export controls. Do you feel that they're creating bottlenecks for UK patients?
I my direct experience, of course, with UK patients is limited. As I've talked to you before, I am now a Londoner, and also that's a hard thing to say just because I just moved there a few weeks ago. But I live in Washington
Welcome.
D.C. and I live in London. I do know this, Glenn. I've paid my first council tax payment, so I guess that applies. And I have a cell phone under London. But what I can say is that we do know that the tariff bottleneck that was likely going to be there likely has been mitigated some by this December deal that happened. But that still is going to create the tariffs broadly and also kind of the UK's policies broadly still are going to create some downstream effects for patients. So this buy American kind of idea, if you think about what happened, is that many of the pharmaceutical companies they have a desire for profitability. I mean, let's not get it twisted. Healthcare companies that are for-profit companies, they ultimately, at the end of the day, they want to make a profit. And when there's a threat for tariffs, and when there is a threat for potential price controls, those pharmaceutical companies are going to try to find out how can we continue to make shareholder value? How do we continue to make profitability? And so they will do things, they will leverage those policies in ways to maximize their profitability, even by either by reducing their expenses or by improving their revenue. So let's take, for example, what's happened with some of those companies that I mentioned, Eli Lilly, AstraZeneca, AbbVie. They pulled out of the United Kingdom for creating their manufacturing in the UK, moving now those plants to the US, all because they wanted to avoid the potential for tariffs and they wanted some level of stability there. So now all of a sudden, people in the United States, when something is created by Eli Lilly, granted it can take 4 to 5 years for a plant to be created, or by AstraZeneca or AbbVie or these other companies, um, it is going to be more expensive because the labor costs in the United States are more expensive. The pricing controls are not there. And so therefore patients can pay a lot more for it. But because of the expense costs going up, that means that these companies have to get their profitability elsewhere. And so for the UK, what could that mean? That could mean that they now have to pay more for drug prices to be able to have access to the same drugs. Or there may be a contraction in drug prices or drug availability because the drugs that are less profitable may not be on access for UK citizens. So I think to your question around what does these kind of buy American policies, how does that implicate or how does that affect patients in the UK? It goes back to where drugs are produced, how much drugs are made, and then the access of those drugs or devices that are available to patients in the UK. And I would submit that the tariff threat and therefore the move of these companies have a direct impact to not only the NHS budget, but also the supply of drugs that the UK would have because of pricing controls. And lastly, I just want to say this is, one thing you didn't mention, I'm a professor, a business professor at the University of North Carolina in Chapel Hill, also a visiting professor at ESCP in Paris and in London. And one of the things that I teach my students is that we like to think of healthcare as drugs, surgeries, hospital, clinics, things like that. But a person's health is so much more than just those things. They are where you get your nutrition, where you get your food. Do you exercise? Where do you work? Do you have a stable job? Do you have a stable income? These companies moving out of the UK are jobs. These companies are communities that are affected, that were thought that there was a promise of something coming there. And those have downstream effects to health as well. And so we can't just focus only on the implications of pharmaceutical pricing or et cetera. We have to look at what does this do to the economics and the economy of these communities where these companies were going to be building manufacturing plants as well.
Absolutely, completely agree. I mean, this could be relatively moot. We could be looking at 3 years, the tariff situation changes, 7 years if he somehow manages to figure out a third term. We don't know about that, but relatively speaking, could be a short-term turnaround. Everyone could be coming back in 3 years' time, but 3 years is a long time in terms of people's health. Do you have a solution to the medicine supply issues in the interim? You don't have to have one.
Yeah, no, I do think that there's something that we can glean from our experience in COVID that I would encourage that there to be considerations. And I think some of the plans that you're seeing, and this goes back to or some of the question that you asked before about flexibility or vulnerability, is that if you were dependent on a single drug supply or component of a drug supply from one singular entity offshore, you are vulnerable. Even having one onshore, you are vulnerable. I remember, so I was the lead of the COVID response for a big national healthcare organization here in the US. And at the time in 2020, I was responsible for 650 A&Es and across the United States in 45 states. And one of the biggest challenges that we had, not a medicine supply issue, but similar, was PPE supply. That all of a sudden I had doctors and nurses that would be exposed to COVID. And how do we get N95 masks or equivalent masks? And I spent a lot of my days working with the US Army, working with other entities around the world, other suppliers to try to find equivalent masks for our clinicians. And what that experience, at least in that moment, taught me is that we have to have redundancies in our supply chain when it comes to, and that's costly, but we have to have redundancies for critical medications and critical components of medications and devices and PPE. And so I would say that one of the important things that the UK needs to think about doing, and this is somewhat dissonant to what we were just talking about, is that they have to incentivize domestic manufacturing capabilities beyond what they've even done before. That's one of the way, and also create those alliances with other countries that create redundancies. Domestic manufacturing is one thing, but we just saw in the United States in hurricane season, not this past year, but the one before, where Baxter, which is a IV medication company that makes IV fluids. Their plant was harmed significantly during a hurricane that came through with flooding in North Carolina and Western North Carolina, which is where I'm from. And the stories, the local stories, and even stories around the United States where people were not able to get the fluids that they would normally have been able to get during pregnancy or during surgery or during different type of medication administrations, they really had to curtail the use of IV fluids, something that's so critical in hospital. So there's been more discussion around the need for domestic manufacturing capacity, but also redundant capacity. And so I think from the UK's perspective, looking at policies that will not only shorten trial approvals to get drugs to market more quickly, but also look at incentives to put the building blocks there for building more redundancies is something that the UK can do. The problem, Glenn, is that's a decade horizon time for many of those things. And so there are some other type of, and I can't go into detail, but I know that there are different types of policies, like allowing drugs to be more available in pharmacies and allowing pharmacists to be able to prescribe drugs or refill drugs. There's also other type of programs to pursue supply agreements through the EU and other countries. I think that's called the Project Revive program that the UK the NHS has been looking at. So the goal here is that no single critical medicine is dependent upon a single source. So that's a somewhat long answer, but one that doesn't have an immediate, this will be fixed tomorrow.
Okay, fair enough. Well, let's move on to the next part, covering workforce and clinical decision making. How is geopolitical uncertainty already altering clinical decisions? Are you seeing treatment delays that trace back to these macro forces?
Yes. So I think I alluded to this at the beginning of the political shock around misinformation. So I think Glenn, your question may be alluding more to how are clinicians shifting or changing, or what is the availability of medications? But as I mentioned before, the anti-science rhetoric that's coming from the United States, out of the Centers for Disease Control and out of HHS, is changing how physicians alter clinical decisions. Remember, clinical decisions are not made in a vacuum. Clinical decisions by physicians like myself, we are reliant upon our past experience, our education, and also information readiness, readily available information in that moment. And so when you have the CDC saying that we're going to dramatically change vaccination plans for children, or some drugs that we knew were very safe are now not safe, or that we're not going to review a Moderna flu vaccine, which now they have decided they will review it. But these type of anti-science type of activities have big implications to how physicians are able to, with ease, treat and take care of patients and give recommendations. I never thought in my years, I've been a doctor since 2004, but I've been a doctor quite some time. But I never would have thought that I would hear the American College of Obstetrics and Gynecology or the American College of Pediatrics say, don't listen to the Centers for Disease Control about vaccines. I never thought I would hear that. And so that is one thing that has changed clinical decision making on the part of physicians and those who support them. I think a second piece is clinical trial disruption, which when Trump came into office, many of you may have heard of Elon Musk and Doge, DOGE, that came in to cut and slash all these different programs. And many of these programs that were coming out of the National Institutes of Health had research sites in multiple different states around the country, some in rural areas, some in suburban areas, some in urban areas, and at academic institutions. Some of these investigations also had cross-country ties to them, with people kind of working on these different type of trials. And these trials, they went poof, gone. All of a sudden, cancer treatment trials, they were gone. There was no money to fund them. And so that has had a direct implication to the ability of clinicians to be able to take care of patients in a trial type of setting, as well as in also anticipation of new type of drugs that will be coming in. So, even though we may think that, well, it's a clinical trial, the implications may not be as big. If you're a cancer patient and you are dependent upon a trial and a drug within that trial to potentially save your life, then the implications are quite huge. And so I think that's another area. And then the third, and I won't go too deep into this now, but I think that the chilling effect of immigration in the United States and the way that immigration enforcement has occurred has created an environment where we are seeing patients not come to our emergency departments. So that's been an issue because of worry of being flagged or potentially even deported, even though that's not supposed to happen. And third, or in addition to that, even physicians themselves who have been on different visa waivers and things have had some concerns. So even though we've talked about these geopolitical kind of uncertainties in the US, do have cross-border implications, and they are affecting patients and whether or not they're seeing treatment.
Now, if the US simultaneously tightens immigration and increases healthcare spending, what do you think is the NHS's realistic plan B beyond international recruitment?
Well, I think first let's kind of talk about what are the challenges are in the US with our own kind of shortages, because there are some similarities and things that can be gleaned. I mean, if you are looking at, the NHS Plan B, it's to train more doctors, recruit internationally, expand non-physician clinicians, so like nurse practitioners, midwives, associate physicians, like we call them physician assistants, expanding kind of pension policies, allowing doctors to have more portfolioed lives with other type of jobs. Those are some of the components of Plan B, and also technology enablement The US is going through some similar things, but there are some structural differences. So, first, and this always shocks my European students when I tell them this, is that physicians end their medical student programs not yet practicing, not yet able to practice without having a consultant that's working with them. We call them attendings, with over 2,000 pounds of debt. Okay, so that's on average. Students walk out with that amount of debt. That has a significant barrier to entry, especially to lower income individuals, because they see my only way to get to be a doctor is to incur 200,000 pounds of debt or $250,000, $260,000 in debt. That's a huge amount of money.
Mm.
For nurses, the debt is also extremely high as well. And the US Department of Education just changed the category of nurses to not be professionals. Therefore, they do not have the ability to take out as much student loan to support them during the program. So we are having in the United States a front end pipeline type of problem. And so this front end problem is really driven by the cost of medical school, the opportunity cost. So in the US, in most cases, have to finish uni first. You have to go through 4 years of university, then you do 4 years of medical school. So you can't practice as a doctor until you are 8 years out of high school. You know, so I was practicing as a doctor in residency. I went straight through at 26 years of age. But then I had to do training, specialty training in emergency medicine. That was another 3 to 4 years after that point. So I was basically 30 before I could actually have an income. That was a real physician type of income, and then had all the debt on top of that. So there's this big front end type of issue. There's also the US government controls the availability of seats in certain specialties. And then there's a big disparity in pay. So if you're an orthopedic physician, you oftentimes are making twice the amount of what a pediatrician would make, and perhaps even more. So there's a similarity here of what we are seeing, of course, with the UK on a front end pipeline problem. It's hard to get into medical school. Okay, should be. But the process is a long process. And if the benefits on the end are not high enough to justify why you would go through that onerous process, then people are making decisions of why they would not go into school. So that's on the front end. But on the back end, many of the problems you are facing in the United Kingdom are similar problems we're facing in the United States. And that is severe burnout, heavy administrative burden, capacity issues. So overworked, underpaid, not enough resources to be able to care for patients. And so I think that when you look at the issues around the Plan B, there's a lot that the NHS is going to have to address. Front end pipeline issues of how do you train more doctors? How do you recruit internationally? And what has been in the UK also an immigration crackdown, not at the extent that we're seeing in the US, but also that. How do you create programs for non-physician clinicians? How do you ensure that as you bring more of those clinicians into the fold, what is the rigor of the training? What is the pay for those individuals? Those are questions we are having to deal with now, and we have a much, much more developed nurse practitioner, midwifery, and physician assistant program. But there's something interesting, Glenn, that's happened is as those mid-level, and we don't love to use the term mid-level, but I will for this purpose use that mid-level physician assistants and nurse practitioners. If you do the math, the cost of the barrier of entry for them is less. And even though they may make less on the back end in the United States, because of the barrier of entry is easier, many of them are saying, why would I want to be a physician? I can still prescribe, I can still take care of patients, I can still see them, and I'm making less. But then you lose kind of some of your specialty physicians on the other side. So there's kind of a flexibility and a recognition that these policies have implications. But then the last, I would say that we are starting to see in the US, and we're seeing it much more accelerate much more quickly than other parts of the world, is when the use of AI to help reduce the workload. And so if we know that there's a pipeline problem on the front, we know that there's a problem in the middle of the pipeline when doctors are being doctors or nurses are being doctors, but they're leaving because they're getting burned out. And when you talk with them, a big reason that they're leaving is because of the lack of administrative support because they're doing a ton of administrative duty, which is something that we didn't train to do.
Mm.
I didn't go to medical school to do 60 to 70% of my shift sitting in front of a computer typing. So the advent of some of the AI technologies to really help with workflow, to help with reducing administrative burdens, is something that a part of the Plan B that I think that the U.S. is doing, that the U.K. should also do. So it's comprehensive. It's not any one magic bullet that's going to solve the problem, but even though the UK has a different system, a closed system for the most part with the NHS, you're facing very similar problems with people leaving and people burning out and wanting to identify other types of work. And so I do think it can be done, and I do think that it can be improved, but you have to really understand that this is going to take time and that it's going to take dollars to make to or excuse me pounds in your case to make this work.
Absolutely. Let's move on a little bit, but delve slightly deeper into the AI
Sure.
subject as you touched upon there. Now, the US is pursuing a lighter touch AI regulation, for good or for bad. For the UK, do you feel that the bigger risk is being too slow to adopt beneficial tech or too fast in adopting tech built for a different, and by that I mean profit-driven, less equitable system?
So I probably sit somewhere here in the middle on this. Again, not the most satisfying answer, but I do see that there is a positive in allowing for innovation and technology to flourish and build. But if you, I write a column for MedPage Today, and I talk a lot about the importance of rigor around the regulatory space around AI, which would be somewhat dissonant to saying like let AI flourish. And here's the reason why, and you alluded to it. If we are creating AI or innovators are creating technologies that give clinical decision support and it's not vetted, audited, it has the potential of creating widening disparities in equities because the garbage goes in, you're going to over time get garbage out and more of it. That's one. Number two, I do believe that there's a lot of questions that we still have unanswered around what level of technology, and we'll just use AI globally. There's of course many different types. How should they be engaging with the patient? Should they be dictating to the patient things like, okay, you can get your prescription refilled without a doctor? That's happening now in the state of Utah. And should that be done in the UK as a way to kind of mitigate the number of clinicians needed for doing something? I don't know the answer of that yet. That's now a pilot program, but in some respects, one could say, yeah, that makes sense. On the other, it's if the patient is responsible for putting in the information for their refill and their questions are not being asked appropriately, and there's not triggers to be able to pull in a clinician to do that refill. Not all refills should be refilled. And so you need to ensure that there's some level of rigor and regulation there. So what I like to say is we need to have innovation. We need to allow innovation to flourish, but we also have to have guardrails to ensure that patient privacy, patient safety, clinician safety, and clinician privacy, and also clinical soundness are all maintained. We've certainly been hearing stories about using different types of chatbots and AI solutions and language models, et cetera, that can end up causing problems for patients and have really negative consequences. That all said, we also know that humans are humans and they make errors too. And so there is a way for us, I think, to hybridize these two. Um, what I will say, Glenn, is that at the most important gap that I see, even in reviewing some of the NHS plan and then talking with as I work with founders, many of which that are working on some type of health technology that has AI, is that you must include clinical staff in the design, in the implementation, and the change management. Technology for the sake of technology is worthless if clinicians are not using it and using it effectively and able to give feedback. And the biggest thing that I see as a gap at times, in my experience, has been the lack of clinician engagement and involvement very early on because clinicians are like streams and rivers. They are going to go to the paths of least resistance. And if there are more clicks to do, more sites to open up and sign into, if there's more of a challenge of just being able to navigate a system, they're not going to use it. So if you want technology that's usable, that's that's able to be supported and grow and be good for patients and clinicians, you got to have clinicians very, very early on in the development and the implementation and change management associated with it.
Mhm. I mean, to that point, what are your thoughts on the criteria healthcare leaders, clinicians could apply when assessing these new technologies and partnerships, especially in the context of lighter touch AI regulation?
Sure. Well, the first is does this have direct implications to patient safety? And then that opens up a whole nother box. Is there going to be, is this dictating to the clinician how to treat the patient, or is this supporting the clinician in the decision making? And so I think that's question one. And actually, the Food and Drug Administration, the FDA of the US, has delineated software as a medical device, devices that actually create some type of beyond just clinical decision making, actually have diagnostic capabilities versus something that's truly supporting the clinician. So research, background research, those are the things that, would support the clinician. Ambient technologies, listening to clinicians and patients talk, et cetera, and putting that in. So I think the first question just like when the FDA or MHRA or other regulatory bodies are looking at devices, what is the potential implication of this device? So I think that's a first guardrail, is like, what are the downstream effects? The second, though, is does this work in an interoperable fashion? So is this a standalone system, or is this a system that integrates seamlessly within other type of electronic healthcare records or patient records? Does this integrate within also other data repositories so that it can continue to improve, and also be something that can be queried later on? So I think that's a second piece. The third, and I mentioned this before, is it clinically useful? Does it actually help improve clinical workflow? Does it help improve the clinician's day? So I think that's a third piece of the rubric that I would use. And then there's a fourth. And this is where I think when I talk with clients that want to come into the United States, there's oftentimes a misunderstanding of who is the buyer, who's actually buying this product. The clinicians are not buying it, they're using it. It's the hospital systems that are also often buying it. And so, because the majority of our hospitals in the United States are for profit, there has to be a financial return on that investment. There has to be an immediate improvement or reduction in the cost, because hospitals in the US on average are running on low single-digit margins. So any of these technologies that add a lot to the bottom line or add a lot to the expense, without having improvement to the bottom line, are likely going to face adoption barriers. So again, I would say, is it safe? What is the clinical usefulness? Is it interoperable? How does it affect workflows? And then what is the financial kind of implications of it? And then I think the last one is privacy. And like, what are the privacy implications of this? How is that information being used? So those are kind of the five pieces that I would say that I would start looking at. I probably missed a couple, but we'll start with those five.
I felt pretty comprehensive. Um, I mean, this feels like a very for today question section. Planning for volatility. In your opinion, what's the one piece of actionable intelligence that NHS trusts should be demanding right now to navigate this new landscape? It doesn't have to be
You know,
just one piece.
yeah, I think that's a very, very challenging kind of question, in saying that I believe that the first thing they should be demanding is looking at, I don't think it's a singular answer, because you're going to miss some critical things. And I think it goes back to my answer on AI systems, is that, as I tell my patients, there's two things that you always need to think about when you're coming up with business decisions and policy decisions. And that is, number one, how will this affect the patient? At the end of the day, how is this affecting our patients? And you do have to understand all the different stakeholders involved, because whatever decision that is going to be made, whatever new policy, whatever business decision, new program, new scheme, all of those things are going to need to be kind of filtered through a rubric of who are the key stakeholders, how are they going to be affected. But at the end of the day, how is this ultimately going to be facing and dealing with? How is this going to affect patients? And then the second piece of it is, and I alluded to this in the first part of the answer, is that really understanding the stakeholders. And so in the course that I teach at University of North Carolina, Chapel Hill, and at ESCP, I talk about the 5 Ps. And those are focusing on the patient, understanding the policymaker, understanding the payers, understanding the producers, and then understanding the policymakers within the system. All of the, or the providers, excuse me, I already said policymakers. So understanding the providers in the system.
Mhm.
If you can filter ideas and thoughts and what the UK needs to do to help fix some of their problems, they must think through that rubric because all of those pieces are critically involved and all are going to need to have a seat at the table.
Ultimately, does geopolitical exposure force the UK healthcare sectors, both private and public, to become more insular and self-reliant, or perhaps more diplomatic and alliance-driven?
I think, as we discussed, it's got to be more alliance driven. I think we talked about before how having flexibility may have been good for a while and still it's an ish. You need to have some flexibility. But I think with the uncertainty that's coming out of the United States and the chaos, having some alliances with the EU, with other countries, and other Commonwealth countries, I think that makes a lot of sense for the NHS to rely on medications and also other devices so that they are not overly from other countries. They can be reliant on other countries and also themselves, but not overly tied to the United States. And so I think having that kind of that reduces in some ways their vulnerabilities, as we discussed before.
Let me open this up to any questions from the participants joining in. I will take just a brief moment because, as you said, Adam, you have moved to the UK now, so maybe, an opportunity to explain a little bit more about what you do, and now that you have a UK footprint.
Sure, sure. I'll give you a slight bit of background. So I am an A&E physician by training, an emergency physician by training, a university professor, do that part-time, but teach every quarter. But in 2022, I started ABIG Health, which is a healthcare marketing, communications, strategic advisory firm that works with innovators, mostly in medical devices, but also in healthcare services in their commercialization efforts. One of the things that I recognized leaving my corporate job in 2022 was that there were so many amazing innovations that were coming out, but understanding kind of the complexity of the healthcare market in the United States, who knew that it was complex, but understanding the healthcare market in the United States and how to navigate that was really a challenge and very expensive for innovators. And as I looked at some of the innovations that were coming out, it made me sad a bit that you had really amazing ideas and great thoughts that could have massive impact on patients and on cost of healthcare and care delivery in general. But they were oftentimes thwarted because of a lack of information about how do you go from the point of ideation all the way to the point of commercialization in the United States, which is the largest healthcare market. We don't have the most people, but we have the most money to be able to pay for some of these services. And so we started with that idea of helping companies come from overseas or even within the United States, navigating the complexity of the market. This past year, we've added several new members to our team, former regulators at Medicare and Medicaid, the FDA, also to really help solidify that commercialization plan. And so for me, I work much more on the strategy and ideation side of thinking about who are your buyers, how do you communicate to those buyers, how do you navigate this complexity of the market, and also educate on, well, you need to think about getting through the FDA. Well, once you get through the FDA, the story's not done. That's just chapter 2. You need to get through Medicare and Medicaid for coverage. You need to understand the hundreds of payers that we have in the United States for insurance payment. So that is a lot of the work that I do with helping companies, and that the work that my team does that I'm very proud of. And so we have had a growth in the European market and decided to put a stake in the ground in the UK. And so, as I mentioned to you before, I now pay council tax in the UK and have a flat there, and also here in the United States. Also, fun fact, our team is distributed around Europe and the UK and the US, and it's really, really exciting to see the growth and also the innovation. And these are from big companies, also from small companies too, that we work with.
Absolutely. Well, everyone listening, it's ABIG Health. Please check it out on LinkedIn. Just a Google it, you'll find it. No worries. We have a note here from Misra, which I think is more of a statement than a question, but good to get your thoughts on it. So it says use of AI has paralyzed the clinician's lateral thinking and decision-making capability. Any thoughts on that?
Well, I think that's a very kind. I think that that statement can be accurate, and I think that I certainly see that with students. I see that with other types of other type of ways that AI is being used. However, I think that we have to think about it as not just Chat GPT. Okay. And AI is more than Chat or Perplexity or Claude. When I'm looking at AI, I'm thinking about, let me explain a situation. So I'm in the emergency department taking care of a patient, and on a typical shift, I'd see anywhere from 20 or 30 patients. When you think about that, 20 or 30 patients, if two-thirds of my time is sitting at the computer documenting and trying to just translate or recount what I just did, that's a huge amount of time for me to sit and be away from a patient's bedside. There's now ambient AI technology that's able to sit in my ear, listen to the conversation, document the conversation, and also pull information out from the patient's medical record that may flag past history that the patient may not have told me, but now that's very prominent in my new note. We are seeing that 80% of physicians that use this ambient technology have had very positive experiences, reduced burnout, and also what we like to call pajama time, meaning you've done your shift, you finish, you go home, you're sitting in your sweatpants, and now you go back to the computer and you document for the next 2 or 3 hours about what you just saw. So the accuracy in the documentation is there. So I'd be very careful to kind of clump AI altogether into just one thing. The second piece is I think the non-sexy AI utilizations are some of the best. And that is not just using AI technology to help with like clinical decision making or writing things up. And I think to your point, Mishra, that is true. I do around clinical decision making. But I do think that things like helping with the revenue cycle, which is a very important in the United States, or with workflow, demand capacity workflows, and predicting where and when patients will be and how to allocate staffing, that is a very positive thing that we can see that AI can be used and some of these technologies can be used to help support clinicians. But you are correct. There is a risk that if everything is over automated and that we're using a peripheral brain of Claude or Perplexity or ChatGPT or one of these type of services, that it does corrupt the ability for us to think critically. And that's something that's a major consideration.
No, I didn't want to call you on this, but your friend and colleague Laura Zibners says, "Hey Adam, it's called a mobile, not a cell phone." Anyway, we'll move on from that. But she
I'm
does ask.
trying. I said A&E, Glenn. I said it. I mean, I'm trying.
I was going to let it slide. Don't you worry.
I'm saying pavement now, not sidewalk. I'm lift, flat. I'm getting there. It's just taking a little time. She's
As
been
long
there a
as
little longer than
as
me.
long as you know the noise that you make when someone drops a glass at a pub, that's all you need to know. We'll work on that one. She asked, "What are the things you are most interested in understanding more about the UK healthcare system?"
What you broke up just a little bit. What was the
Sorry.
most interesting?
What are the things you are most interested in understanding more about the UK healthcare system?
Yeah, so I think I'm going to give a kind of a statement and then answer that a different statement and then answer that question. In the United States, we have this exceptionalism that is kind of trained into our brains that I think is wrong. And as I have trained and talked with students and educated students in France and in UK and of course back here in the United States, what I learn and what the students learn is that no healthcare system is perfect, and that there are a lot of negatives and also a lot of positives. And when I think about the UK's system and the NHS, you spend significantly less than the United States, but yet you have a much longer life expectancy than the United States by 3 or 4 years. You have better outcomes than we do on many of the chronic diseases. But yet you do have shortages of doctors, nurses, medications. You have longer wait times than we do. And so what I'm really curious to learn is how can the UK continue to improve on the NHS, shorten wait times, improve supply, continue to improve life expectancy, and yet still spend so much less than we do in the United States? And even with increasing the amount of funding, how can you keep a system in balance that does the things that we want them to see? So that's what I'm excited to see. And I'm excited to see, and that's going to take a long time. I mean, I'll be a merry old man when I kind of start to see those things, hopefully, or maybe a younger guy when I start to see those things. But I want to see how the system operates and really give that compare and contrast. Because if you have money in the United States, you can get services pretty quickly. But if you don't, there's long wait times. There
Mm.
may not be a doctor to see you. So those are poor patients are having those issues in the United States that are more wealthy individuals do not. And so I'm excited to see that and interested to learn more about that juxtaposition between the two systems and how you're making it work with less money and how with a little more investment, thought, and process, and also alliances, you can even improve on what you've already got.
Fantastic. Adam, thank you so much for today. Thank you all for joining us today. Thank you to Dr. Adam Brown for sharing his invaluable knowledge and expertise. Our contact details are here on the page. So if you do have any further questions, please get in touch. Otherwise, have a great rest of your day and the rest of your week. Thank
Thank
you.
you so much.
Take care.